You are listening to the Aizer Health Podcast with your host, Dr. Josh Gilden.
Disclaimer. The information discussed in this podcast is for educational and informational purposes only. Always consult with a qualified healthcare provider regarding a medical condition or treatment. The views expressed by the guests and hosts are their own and do not necessarily reflect those of any affiliated institutions.
So, Dr. Samuel, you go by Samuel?
Rosenberg. Sometimes Samuel, sometimes Shmuley.
Shmuley, I don't know. For the sake of the podcast, Dr. Shmuley Rosenberg. Thank you for coming in. I appreciate it. Give us a little bit of an intro, who you are, how you got here.
So, we'll start from a background, right? So, as a kid, obsessed with medicine. Anything medical related, it was something I was always into. I was always following, I was always reading, I was always curious about my own doctors. It was just something that kind of stuck naturally with me. And then as I got older and had to figure out what I'm doing, or even before that, I kind of knew, like, it was very interesting. When I was in medical school, they did a day where they brought in, the guys who do improv, just to get everybody, like, I don't know what possessed them to do it, but it makes sense. It was all about, like, improv skills. And then the tagline was, it's important as a doctor, as a practitioner, to be able to improv, because the whole point of improv is that you get out of your own head. You quiet your thoughts and you're 100% on listening. I mean, the more that you're listening, the better you are at improv, right? Because if you're just sitting there trying to think about what my reaction is going to be, what my response is going to be, then you're less funny. If your instincts are funny and you're just bouncing off and you're just reacting directly off to what your input is, then you're a lot funnier because you're relying on your funny instinct, right? So the parallel is in medicine. If you're reacting to what your medical instincts are and what your medical training are, as opposed to your own sort of running consciousness, you'll do a better job of listening to the patient and reacting to the important little things along the way. And listen, I'm sure in your line of work, what you're doing, and certainly my line of work, it's the tiny little nuances that almost always the patient doesn't think as important, which is what makes the difference in kind of what you're picking up on, how you react, how you diagnose, how you treat, et cetera. So
That's pretty interesting, because that's relatively forward thinking, right? Like, I didn't get that experience in medical school. I'm just curious how that hit you when it happened. Were you just surprised, like, hey, why are we spending a day on improv? Or
honestly, I was grateful to have a day where I was just going to be low key and not drinking from the fire hose, so to speak. But I mean, they explained it at that point. It was kind of interesting that they even thought of doing that workshop. But I mean, here we are all these years later, and I'm still sort of referencing it, thinking about it now. So it's funny how we got to that point in the conversation.
It's pretty interesting that you say that, though, because once again, I don't know that many medical schools, my medical school didn't do anything like that.
Yeah, that's not a typical thing.
And I was just having a conversation before we started this where, I'm not in the medical school education. I mean, in as much as I teach medical students occasionally, they come on shift, residents, so I'm part of the educational process. I'm not inherently associated with a medical school where I'm driving what their education is, but I was griping, once again, not participant in the field, so I can only gripe so much, but that, we learn things in medical school, like, and you probably learned this too, right? When you listen for lungs and you're like, egophony, say EE, 99, all these things that clinically, if they had just taught us point of care ultrasound to look at the lungs, this is what a beeline looks like. And once again, I don't want to gripe because I don't know that the technology and information may not have been there then, and maybe it's moving that direction. But like this improv section, class that you had, like, that is so useful, and the point behind it is so poignant that you kind of wish everyone was doing it, right?
Yeah, I mean, I mean, you bring up you're packing up a lot of stuff here, which is, how much relevance is there what you're taught with what you're actually in practice, and I think that. And I know we're kind of all over the place here, but you brought up one of the issues that I have with the current educational system is this over-reliance on technology. Like, there's a push to bring in technology. There's a push to bring in higher advanced diagnostic tools like ultrasound, for example. But then we fail, or we don't teach people what to do when they don't have access to the ultrasound machine, right? So when I was teaching residents, when I was working for a hospital that had a residency program, and there would be residents working with me, if they had to learn, or if they had to perform an injection, at that point they were pretty efficient and pretty proficient with doing injections, they would opt to do the ultrasound. And then I would say, hey, do this without ultrasound. You know, obviously not in a scenario where you needed ultrasound. You know, it's something that was, you know, a target that was, you know, you didn't need the ultrasound to do. And even though in practice, it's definitely, it's definitely better to do it with the ultrasound just in terms of targeting. But I felt that it was important for these guys and girls to know how to do it without the ultrasound. And oftentimes they had no clue. And it was like, all right, we're going to figure this out. We're going to go back to basics. We're going to look at the anatomy. These are your anatomic landmarks. You know, what are you going to do if your ultrasound machine is down? What are you going to do if there's a blackout? What are you going to do if you're in an office where they don't have an ultrasound machine? How are you going to perform then? So I think what you're bringing up also is, you know, while it would have been nice to know what things look like with ultrasound, but yes, it's important to kind of go back to those fundamentals, because oftentimes you're going to be in a situation where you have to rely on your fundamentals, and that helps to kind of bolster your reflexes or your intuition. You know, that's, if you just, it's an over reliance on technology, you're not going to sharpen that what's the word we were using before?
Clinical intuition.
Intuition and your basically your reflex, your
right.
natural response to an input. So it's going back to that same point with the improv, which is like just to be able to create that innate medical intuition and that reflex. Mm-hmm. And so I think the tools are helpful, but don't take away the fundamentals.
Right. I agree with that. It's actually when I started working in a clinical fashion and practice where I didn't have all the tools at bedside, right? So emergency room physician, I'm lucky I get to have the CAT scan and the x-ray, and I get to schlep the tech in at night if I'm worried about a specific ultrasound like ovarian torsion or testicular torsion, something like that. And I had all the tools in the toolbox readily available. And then I came to practice in an environment like I currently practice. You know, I still have that experience as well. But when I didn't have x-ray readily available, I didn't have CAT scan. Well, how do I hone, right, and use my clinical acumen, my physical exam skills, so I can get the most information out of it? So it's slightly different too, because, you know, what you're saying is, well, what do you do when you don't have that stuff? What I'm saying is sometimes what they taught us in medical school was not based off of great literature and like good likelihood ratios, right? Like, I don't know what the positive likelihood ratio is if someone says 99 and you know, tactile fremitus and that kind of stuff. It was taught, and it is taught, and I'm not going to claim to be an expert in it. It just, sometimes I think teaching just accelerates additional teaching, like for the sake of teaching, right? Because it was the material that was taught. It's not changing over time necessarily at the same pace with the technology itself, you know? But yeah, people have to learn to do it both ways, right? So it's probably funny. I imagine they didn't look at you very kindly as you said, hey, put the ultrasound down, use landmarks.
You know, they took to it pretty well. They were kind of surprised themselves that they didn't, I mean, it wasn't like, I wasn't yelling. Right. I mean, it was just, you know, hey guys, we need to think about what happens if you're in a situation and you need to do this injection and you don't have ultrasound, or your butterfly's not charged, or whatever, you know, that, you know, let's just know how to do it. And I think it brings, again, I have no problem with using technology and advancing technology and rethinking what we teach and how we teach. And I think that needs to be an evolving process. But the point of it is, I think if you're the more fundamental that you're approaching anything and understanding why you're doing what you're doing, and then build on that with the available technology or available resources, I think that makes you not just a better practitioner, but just a better human being in this world. You know, be deliberate about what you're doing. So how does that get back to our original point? That's the better question. But I mean, in terms of just, the basics, the basics in physical exam, again, if you know why 99 sounds different in certain conditions, then you'll understand what you're looking for. If you understand what you're looking for, then you'll understand what it is that you're seeing on the ultrasound or the CAT scan or the lab results, and then be able to kind of bridge the gap fundamentally in how you're approaching that patient.
Right. I guess what you're saying is there tends to be an over-reliance on the thing that maybe is the most correct, right, and the most useful at bedside, but it also leads to a skill decay in the other things that maybe need to go along with it, right? So if you don't listen with your stethoscope and you're going straight to, you know, doing a chest X-ray, for example, right? Like it would be a cardinal sin in an emergency department. Someone came with shortness of breath, and I'm like, well, I'm getting the X-ray anyways, so I'm not even going to put a stethoscope on the guy. Well, okay, how do you know he could have a collapsed lung? And if you just listened and it was diminished, like, hey, that's really weird. We have to get this X-ray faster, right? So sometimes there's an over-reliance on the things that are maybe make our lives easier, but it leads to a skill decay of maybe the skills that are more fundamental.
I think at the root of it, it comes down to when you're doing something, know why you're doing it and know what you're doing with that information when it comes in. And I think that comes down to when you're examining a patient, what are you going to find and how are you going to react to that? If you're ordering a test, what are you going to do with those results? Same with imaging studies. Again, it doesn't have to be, you don't have to write it all out ahead of time, but just sort of in your head, there should be these short pathways, which is I'm doing X to determine Y, which is going to help me get to Z.
Mm-hmm. Now, I'm glad we're talking about this because I think it segues nicely, right? Technology it's only getting more advanced. It's not getting less advanced, right? So AI is, I think, probably unarguably, it's going to be centripetal. Like it's going to be a focal point of the future of healthcare. At least it's the buzzword that everyone's talking about. But I think there's a lot of truth behind it, so it's valid to talk about. Is there any way, I guess the first question I'd have is like, what's going to be the biggest benefit for you or that you see in your clinical field, and what's going to be the biggest detriment from using AI and integrating it?
So I think we're still figuring out AI to in a large degree. So to me, the way I think of AI is kind of taking a really powerful search engine and then taking it a step farther, which is applying logic to the results that search engine is bringing you. At least that's kind of the way I know it's more powerful than that, but in a simplest state, I think that's the way I look at it now. And then the other piece to it is also you can add a lot more inputs to it than you could to a traditional search engine, right? So you can add video, you can add picture, you can add voice. So the question is, going back to how do I see it affecting the way I practice? How do I see it affecting healthcare? I think the world at large is still trying to figure out what to do with this. So I think healthcare as in our own little world is also trying to figure out what to do with this. I think the immediate effects are it's making it, one of the nice parts about AI is it's making a lot of our busy work more efficient. So drafting letters, crafting, anything that's written that would normally take a lot more time, even responding to an email is now becoming more efficient. You could do that faster. They're building, Gmail is building those tools into their responses. Every return, there's another place to use it. So I think in terms of efficiency and reducing some of the busy work, there's a definite role for that and that to be implemented immediately. And I think all of us are doing that, like writing letters to insurance companies. We still have to put in the inputs. We still have to say, hey, these are the points we want you to highlight, but at least the drafting process will be more efficient and will take less time. So I think that's role number one. Role number two, which we're still trying to figure out, is the documentation. So again, taking that step back, we're trying to figure out how to use it to reduce our burden, the busy work, the burden of work that we have to do as healthcare providers. So if we can use it, there's a lot of work in terms of implementing it with documentation. So if we have an AI tool that's listening to the conversation that's going on with our patients, and perhaps we're feeding it little nuggets as we go along, and that can help to draft a note that's used in whatever EMR you're using, then that makes you more efficient in an already busy schedule. So I think that's kind of the immediate positives that we're going to see. The negatives, I think, especially when people start to rely on AI for help with diagnosis, for help with treatment, we get into over-reliance. Again, we're not utilizing our own powers of deduction, our own instincts that we've honed over years of clinical practice. And we're sort of shutting that out and relying more on the AI side. I think we may not get the most accurate information from the AI tool that you're using. Who's to say that information is the most up-to-date, the most accurate? So I think that's an issue too. And then same for treatment options. Once you punch something into AI, what is that information you're getting back? So I think the latter of those things are going to get fine-tuned probably really rapidly over the coming months, and there's going to be more ways of verifying the data that you're getting. So I think that's going to come back to their original issue, which is, hey, how can we maintain our professional instincts, our medical instincts, our treatment instincts without and sort of take the best of it, what AI is going to offer without dulling that.
Yeah, I think Dr. Google is going to be a thing of the past, right? It's going to, people in 10 years, you're going to say, oh, Dr. Google. And someone's like, what are you talking about? It's Dr. GPT, right? Like that's going to be the go-to for most people. And I think you're right. There's obvious pitfalls there where you could put in the same prompt and it'll spit back two dichotomously completely different answers, right? You don't know how it's basing that information at any given time. So something to be wary of, certainly from a patient perspective, right? Like the classic thing that happened with Dr. Google is someone came in and is like, doctor, I'm worried about cancer, right? Because that was like number one on every possible symptom list that you would give to Dr. Google. I think Dr. GPT, so to speak, I'm not trademarking that. I don't think that's out there yet, but I know that there's various AIs, right? People are going to go in and probably put in their prompts at home and come in and be like, I've got a meniscal tear. And you're going to be like, well, why do you think you have a meniscal tear? And you're going to have to go through that web of information as well. Okay. But as far as AI is considered, I agree with you that it's going to, it is and will help us with documentation. I currently use an ambient listening program for some of my patient encounters, and I am blown away by how it organizes and efficiently puts together an HBI for me. Right? Like I couldn't do it better personally, and I would certainly spend more time doing it. I couldn't ask scribes to do it better if they were doing it. There are other things that it absolutely lacks. And I've had this conversation with the company that we've used. Like, I don't understand why they can do an HBI, a history of present illness, so well. And then I ask it to put a treatment plan together, and it gives me like a 2-sentence bare bones answer. So I've actually had some conversation with them about ways to maybe improve that. But I think for people to at this point ignore AI as part of their everyday life in general, but certainly as part of the medical care, is probably puts people at a disadvantage. Like you said, if you're a great doctor, but you spend most of your day doing prior auth letters that could be generated in a second, then what are you doing with your time really? So it comes down to using it in the effective manner. But like everything else, I love that we have the Maimonides prayer behind us, right? Because there's always an emphasis on there's a center path for everything, right? So if someone's a high utilizer and utilizing appropriately, then of course you're going to have a bad product. If someone's a non-utilizer, not utilizing it at all, you're also going to be wasteful in some regard. So the question is, how do you implement? And it's similar to the question I imagine years ago when Google was introduced. It's like, oh man, I can find out everything I need to do with my Google search, right? But Google searches aren't always correct, and the same thing's here, although it seems to be a little bit more accurate for sure. Going back a little bit, you had, I'd asked why you ended up here in medicine, generally, and in this little blue room that we've created specifically. But you mentioned kind of doctors when you were a kid. What was that? I mean, just going to the pediatrician and you were impressed by the reflex hammer? What was the situation?
It might have been that.
Yeah. Well, I mean, you use a lot of reflex hammers, so.
I do have a way with the reflex hammer.
Yeah.
There's no question. I ask myself this question a lot. Like what drew me to it? And the answer is I don't know. It just seemed like natural to me. I liked elements of it. I liked the personal connection that you have with people. I mean, I don't think I could put this to words when I was 9 or 10 years old, but from all the, my little world of the different people I saw doing different things, I was like, hey, that's cool. They get to, the science part of it was interesting. The personal connection thing was interesting, actually helping people get better and feel better. I think that part to me was interesting, but again, it wasn't like an intellectual decision. Hey, you know what? I think I like this field because of A, B, and C. It was just like sort of natural. And then, growing up, I would convince myself all the reasons why I shouldn't do it. And it was,
what were those reasons? It
takes too long. I'm probably not going to get into medical school. I'm probably not going to get into residency. All the doubting stuff. It's too hard. It's a time commitment. It's just a lot easier to do a zillion other things than to go into this field. And when it came time to sort of make that decision, I was like, well, I'm not going to just completely shut this out. Like, this has been in the back of my head for a long time. So when I started going to school, I was like, my thought was, I'm going to take a couple of the classes. We're going to do some science classes. We'll see how that goes. And that'll probably do it for me. Like, I'll do those classes. I'll fail. I will be completely disinterested. And then I'll get it out of my system and move on and become an accountant like everybody else. So, that didn't happen, thankfully, and the science parts, I'm not going to tell you I aced every class I took, because I didn't, but it definitely piqued my interest, and, my advice to everybody, which is the advice I gave myself at that point, was just put one foot in front of the other. This is what I got to do today. This is what I got to do this semester. And I did it. Where am I now? What do I need to do? And I kind of followed that through, and one thing led to another. And, by the time I was done with school and applying, it was the same thing. Okay, well, if I don't get in, then I won't get in. But I did get in. So and that kind of went from there. Look, and move, fast forward. It's hard to imagine now that I've graduated now that this, we're not going to say how long it was, but long enough.
Don't date yourself.
I'm not. Although the gray hair may give it away.
We can change that on camera. Don't worry.
I hope you can.
Yeah, we can color that.
Yeah.
So
going forward, it's like, and how do I end up in this room? It's like, I end up we're both from doctors. There's a tremendous amount of Yad Hashem. There's a tremendous amount of which I've seen, you're looking back at my history, how did I get to this point? It's because of all these little seemingly insignificant times in my life where I thought, hey, I'm supposed to be doing that, but a little nudge in a direction led me somewhere else. And next thing I know, I'm kind of going into a different field, a different job, a different whatever have you. So even the specialty that I choose, I didn't know it existed before I went to medical school. When I started medical school, I put my money on I'm either going to be a pediatrician, maybe a pediatric subspecialist, or an internal medicine doctor. And then push came to shove, and I did those specialties and rotations, and I just didn't like them. I didn't connect to it. It wasn't for me, and it was one after the other that I just didn't kind of feel like I was a part of it. I didn't feel like and then someone in passing who I kind of he was a year ahead of me, and he's like, "Oh, I'm doing physiatry." I'm like, "What's physiatry?" "Oh, you gotta check it out." And I did. It sounded interesting. I did a rotation, an elective with an outpatient pain guy, and that seemed interesting. And then I set myself up for a fourth year sub-I or sub-internship where I did in an inpatient rehab center, and it was an amazing experience. And that was that was it. I walked in, and I was a part of the team, and I felt good, and I saw patients doing well, and I saw patients improving, and I was like, I need to be a part of this. So that's kind of how I got to. So again, my point with that little anecdote is like, how do I get to this point? It's all these little steps along the way where I kind of was nudged in one direction, nudged in another direction, and next thing I know, I'm working here. So
next thing you know, you're in a blue room talking about how you got here
with some fantastic folks.
Yeah, it's funny because that story resonates with me. I'm absolutely not the smartest kid in my class. I'm probably not the smartest person in the room right now, but although there's 3, so I've got a 33% chance. So at least that's good odds, right? But the entire process of being pre-med and then medical and then finding your people, as I put it, right? You said that you had to just experience a group of people and a specific field of medicine to just look around and be like, this feels comfortable to me. And you can't necessarily put into words why it feels comfortable for you, but it's the kind of place that you just think you're going to excel at. And that's a pretty awesome story. The other thing is that, I'm trying to think back to my, because you got your inspiration as a kid, you just loved it. I'm like thinking back to my first pediatrician visit. Shout out to Dr. Kolsky. I kind of remember, you get thrown on the deli wrap paper that they have. I think that's a classic joke, and you just kind of get moved around, and they push on your belly. You don't know what's going on, and you get the, God willing, you get the sign of clean, a bill of health, and you get slapped off the table, and you're good to go. My passion came later in life when I became an EMT, and I kind of felt a little bit more of a drive at that point. But everyone has a road to get here, and I was talking before we had started recording. I was talking to someone else about how being the most intelligent doctor does not make you the best doctor. And that's really the point of this podcast, if I'm being honest with you. It's not about your level of intelligence. And I think AI is going to make it even less about your level of intelligence as time goes on. Not to say that doctors shouldn't be well-trained and very intelligent, but there's more adjuncts out there. There's more help, right? I've said it before, I'll say it again. I think it's attributed to Teddy Roosevelt. No one cares how much you know until they know how much you care, right? If you're not showing someone in a room or in this forum why you do what you do, at the end of the day, there's so much, and I was also speaking about this, there's so much information out there in the world right now. We don't live in the world of no information. We don't live in the world with the correct amount of information. We live in the world where if you want to find something that supports that bee stings causes, pick your disease, if you Google it, ChatGPT it, you will find that is the case, whether it's true or not, right? So it's kind of past the buzzwords of disinformation or misinformation. It's the world of you can get any information you want, right? So how do you know when you go to a doctor's office, hey, I don't know if this is the brightest guy, I don't even know if he has the correct information. So how do you know if you should listen to that doctor? So I think we're circling back to how it used to be where like you connected with a physician and you just listened to whatever they said because you didn't have any other information. So now we're in a world where it's the same thing. The point of this is you have to connect with a physician because when you connect with them, it's like, this is my mahalach. I feel a kesher. I feel a connection with this guy. And because I feel a connection, I kind of trust what he says. It's almost like having a rebbe to some extent, right? And it's not saying you shouldn't get second opinions if you have questions or you have to listen to everything that someone says. But if the connection doesn't precede the information, then I just don't think that necessarily that information is going to stick because once again, if you want to find it, it's essentially out there. What was it that drew you to physiatry?
So I think...
And sorry to cut you off, but can you give a little primer? What is physiatry? Because it's a word that no one understands. So.
Excellent question. So I love the field. I think physiatry is fantastic, but whoever decided to call it physiatry is that decision needed to be rethought. So physiatry is essentially...
Everyone thinks you're a psychiatrist.
Everyone thinks I'm either a podiatrist or psychiatrist and some other things too, but... physiatry is physical medicine and rehabilitation. It's a fascinating field. It was originated actually right after World War II. So one of the big advances of World War II as opposed to previous wars was that more soldiers survived their injuries based on their emerging technology, some of the medicine they had available. So you had people coming back from war, soldiers who were maimed, who had what they didn't know then, but were brain injuries. They had amputations, and these people were back now. And some of them had families and they all wanted to move on in life and live meaningful lives. So out of that desire, there were isolated pockets of doctors who were treating these people by optimizing, making sure they had the appropriate therapies to get them walking again, making sure they had the appropriate prosthetic devices if they needed it, and figuring out, kind of putting the pieces together of what these people who had suffered a devastating injury were able to, what did they need to get them past this or as far as they could go and be able to lead meaningful lives. Eventually these folks coalesced and joined the college or joined the specialty or created the specialty of physical medicine and rehabilitation. So it's kind of tough to define exactly what it is. I like to think of it as sort of a mix. If you took an orthopedist and you took a neurologist and you kind of combined them, that's probably most of it. Again, we don't do surgery, so we're not full orthopedic doctors, but we're kind of taking the fundamental understanding of the nervous system, both central and peripheral, and understanding the musculoskeletal system and combining the two. But we're also taking like 3 dashes of a physical therapist, which is, okay, what are we doing with that information and how are we actually applying it to the individual patient? So to put it more succinctly, it's the specialty that focuses on patients' functional ability. So what set this patient's ability to function at their highest level? What's setting them back? How do we correct that? And how do we get them again functioning at their best? So it's a broad term, but we see a broad spectrum of patients. Like we're seeing, so most physiatrists today are working with patients who have musculoskeletal issues. So a lot of pain management, a lot of interventional pain techniques, a lot of musculoskeletal issues. So we're dealing with the aches and, I like to call them the aches and pains doctors. The patient comes in, they have acute pain or they have chronic pain, figuring out what the root of it is, figuring out what we can do to kind of get them functionally to improve and also treat the pain so that they can kind of do better. And then there's the another big subsection, which is the more general physiatrists, which tend to see patients who have kind of devastating injury, devastating illness. So amputees, neurological patients, so patients who've had a brain injury or stroke or suffer from some type of a central nervous system disorder like a Parkinson's or multiple sclerosis or any others. And then there's within that world there are subspecialties, where folks can go and do a fellowship in brain injury or spinal cord, and same for pain and sports injuries. And then there's an even smaller subset, almost really tough to find, which is pediatric physiatrists, which is folks who do the residency in physical medicine rehab and then do a fellowship in pediatrics. They actually get maybe don't quote me on this, but I believe they get board certified in regular pediatrics as well. And it's a pretty lengthy fellowship. And they're focusing on kids who either have a devastating injury or illness or are born with things like cerebral palsy or other issues, and trying to figure out how to get them more independent, more mobile, get them to their functional best. So, long answer for a short question.
No, I like the answer though, because it kind of, physiatrists to me are the ER doctors of like rehabilitation, right? You could be seeing someone with a traumatic brain injury, someone who has a regular extremity MSK, musculoskeletal issue. There's just such a gamut of patients that could be seen that need some degree of rehabilitation. And I find that in a lot of specialties, almost there can be I don't want to say monotony, but certainly a routine nature to the patients that are being seen. But like when you're a physiatrist, sure, you'll have your bread and butter, but like, I mean, theoretically you can have your hand in so many different areas, which is kind of fascinating. What would you say that treating pain has taught you about how we age and kind of the best ways to age in general? Like, I would say pain is, chronic pain is a real thing, right? It's something you deal with regularly, I'm sure. And it can be debilitating, right? So what are the things that you treating patients have kind of taken away for yourself, like how to age, quote unquote, gracefully, which I think is a pretty hot button topic right now in general, right? But you get to see day in, day out what happens, or the sequela of, let's say, 20 years of maybe a lack of understanding how one needs to treat their body.
Okay. That's a pretty deep and loaded question, but I'll try to, so let me break it down by the way that I approach pain. Essentially, there's two types of, well, even before then, pain is a very subjective experience, and pain is one of those things that you cannot, if you're in pain, God forbid, you're in pain, if someone's in pain and wants to explain to their doctor or wants to explain to their friend or their neighbor how they feel, they can't. They can describe certain things, but I know what burning pain feels like to me, but I don't know what burning pain feels like to you. Right? I think it goes down to like, I know what the color red looks like to me. I don't know what the color red looks like to you. Maybe you see it as I see blue. So I kind of think about these things as a whole. So what's my point with that is, when a patient's coming in and reporting pain, it means very different things to different people. So I think my approach is, number one, try to understand or try to figure out the nuances and see if it follows a pattern. And then within that, there's the acute pain. So somebody was feeling fine, no issues, and then something kind of hit. And now we got to figure out what that something is. So that's sort of like that, almost like the emergency room side of things. Try to diagnose, try to see if it fits a pattern, determine if it's something that has danger to life and limb, and ultimately try to get the patient feeling better. And sometimes those things are unavoidable, right? So classic pain that I see in the office, somebody does something to their back, they have a pinched nerve in their back or a lumbar radiculopathy. That can happen to someone who's fit as a fiddle. That can happen to someone who's pleasantly plump, and a little overweight. So there's some degree of that we don't really have control over that. And then there's the sort of patients who struggle with pain for a long period of time. They have a chronic issue. So maybe, back pain for several years or shoulder pain for several years. And those are sort of tougher to tease out how to treat them. A lot of it is trying to go back to those fundamentals of what's the problem here? Can I trace it to one problem? Or is there several issues? I think what I've learned and what a lot of doctors have learned is, that obesity can be a big trigger towards pain issues. I think that somebody with extra weight is putting stress through their joints, is putting stress through their spine. You multiply that by years and years, and that's a lot of actual stress. And we'll see degenerative changes. We'll see wear and tear. And those kind of things will set up injury to linger longer, right? So why does person A have back pain that goes away after 3 days, and person B has back pain that doesn't go away for 6 months? So I think that's a piece of it too, is sort of the underlying state of their spine or whatever the joint is that's affected. And the biggest factor is if somebody's obesity. If someone is obese and they've had years of putting pressure through that joint and have now worn it down, it makes it that much harder for that joint or that region to kind of get out of it. And then I think there's a flexibility piece of it too. I think that if our bodies are not in balance, we have agonist, every muscle has an agonist to an antagonist muscle. So we need to make sure those are balanced. If there's one set of muscles that's stronger than another one, you can lead to stiffness. Stiffness can kind of give you undue torque to a region, and that can also predispose to injury. So the question was, what can I learn from these patients in terms of how to age gracefully? I think it's staying healthy in general, trying to stay strong, trying to stay balanced, avoiding obesity. Those are the big ones. Now, not everything is avoidable, and we certainly have people who are obese that don't have pain, and we certainly have very skinny people who have pain too. So it's not a general rule, but I think if we're able to extrapolate a general rule from the patients that I see, I think that would be a big one. And again, like I said, even though people who are in good shape can have pain issues or can have an injury, they're going to do better in terms of recovery from those injuries. So I think that's kind of that's the big thing that I take out.
Yeah, I mean, once again, it's like you can almost take any topic and say, pick the point in the middle and you'll be correct, more likely than not. And, certainly from an emergency room perspective, and kind of what I love about this ability that we have here, that we're fortunate to have here, is to have two people from two different fields talking, and there's such a there's a syncing between how we when we see patients, there's common threads. That's what it comes down to, right? Like, for example, from a physiatry pain management, quote unquote, perspective, right? Like, obesity is going to lead to bad outcomes, and it's very hard to get away from it. Like you said, there are exceptions to the rule, right? Someone could be thin and also, right? And from an emergency room perspective, right? Like, we all know that obesity is a comorbidity for 1,000 other endpoints, right? So, and it's not perfect, right? Like, you can have a 40, 50-year-old with obesity who comes in and is having a heart attack, and you can have someone who's 40 or 50 and they're not obese, but they have bad family genetics, and they're also coming with a heart attack. So sometimes people will say to me, well, what's it matter if it's going to happen anyways? And I always say, like, well, just put yourself in the best strategic category, right? Like, you can't prevent everything. That's obviously a fundamental belief for us anyways, but you can set yourself up for success, and that's what it comes down to, right? And there's always this string here of, specific things that every specialty sees, right? Like, if I was sitting here next to an optometrist, which I recently had done, I didn't ask about obesity, and I'm kind of curious now, well, does obesity affect the eyes? But I guess we know that obesity and diabetes, and sure, that's going to cause retinopathy for sure. So there's definitely these common threads in these different aspects of medicine. Something that I don't know if hopefully you can help us with, but the physiatrist's role within the whole healthcare system, right? Like, what is traditionally how people get referred to you, how you refer people out, how people come back to you? Because I feel like you kind of said you're this hybrid of MSK, musculoskeletal, orthopedics plus neurology, and the various types of patients that you see. How do they get referred to you? And then you refer them back out, and then you consequently see them afterwards. Like, where are you within the pathway?
So I think it depends on the setting. If I was, when I worked for a hospital system, I think there was a good understanding amongst the specialties. So we had great relationships with the neurologists, and they kind of understood. So, for example, I worked closely with the MS doctors, meaning the multiple sclerosis doctors, and the movement disorder doctors, and also obviously the stroke specialists. So they kind of knew their endpoint. They knew their role, which was diagnosis, treating a primary disease. But when it came to things like dealing with some of the symptoms of it, so for example, the spasticity or the tightness that can occur in some of those conditions, they kind of knew that they were, although a lot of neurologists do deal with them in the systems where I came from, that was kind of their endpoint. They were like, hey, you'd be better served by someone who kind of understands the biomechanics of the body. And I can go back and give an example as to what I mean with that. And similarly, with the orthopedics doctors that we saw, sure, there's a lot of overlap in conditions that we see, but in some of the larger centers, the orthopedic doctors would sort of focus on the surgical cases and didn't want to be as busy with the non-surgical or more chronic patients, so they would send those to us. And we're sort of a good conduit in between those doctors and other treatments that we may think about, and then B, the therapists, right? So it's oftentimes patients will walk out of an orthopedist office with a prescription for PT. That prescription may not be specific as to what they want the PT to do, and the PT might be leaning on some more instruction, wanting to know what to work on. So we're very well versed in PT language, and we're good at sort of honing in on what we want worked on with those patients, and we're good at relaying that to the physical therapist. and getting feedback from the physical therapist and adjusting. So like I've had scenarios where a physical therapist will call me up after a couple of sessions and say, hey, this is working, but this is not. Should I adjust? Do you want to see him or her again and perhaps offer a different treatment? So we have a good working relationship. There's a stress within the field of physiatry of interdisciplinary communication and care. So we rely on that. So that works well in sort of the tertiary centers, which I think, and then in private practice, most of my referrals are coming from community doctors for the aches and pains, for the back pains, for the shoulder pain, knee pain, what have you, where they kind of feel, hey, I'm better at doing my internal medicine side of things or my regular PCP type stuff. I'm not sure how to, they'll do the sort of first line treatment of the back pain, for example, but they may not necessarily feel as comfortable with doing the full workup, doing the full treatment plan. They may not know, or they may not feel as comfortable as, okay, this patient needs treatment A, this patient needs to see a surgeon, or so on. So they, a lot of my community partners will reach out to me and say, I've stabilized the patient. Can you take over just to deal with some of the nuances? And then in a health center, which is similar to the one that we work in, I think it's kind of a hybrid of the two. We're not necessarily getting a lot of the kind of high level neuro cases that you would in a hospital system, but we do have specialists who kind of also say, hey, we'd love for you to take over where those are. And then, that's the vast majority of those referrals. I think there's a lot of word of mouth. Some communities have more word of mouth than others. I think if you have someone who's complaining of an ache and pain and their neighbor had good success doing treatment A, then they're gonna want similar results, so they'll come in based on that.
It's funny. So in the hospital, in the emergency room setting, I'll see a patient that's geriatric, and I walk them, and I'm like, I'm not comfortable with how they're walking enough to send them home. Like, I don't think it's a safe disposition. It's a safe discharge. So I put in an order for PT evaluation and treat. And that's like the extent of therapy integration that I have, because I just don't know, I know I want them to evaluate. I want them to make sure it's a safe discharge. Sometimes they need a walker or a cane, but it's so limited in scope relative to what you're able to do and the conversations you're able to have, which is why, sometimes I think in medicine, people feel tossed off, like, oh, well, why don't you answer the question? It's like, I wish I had the tools to answer the question better, but like, I'm really good if you're, God forbid, acutely having a stroke or heart attack. And I all of a sudden, when it comes to how you walk, I get really bad at that. But I know a doctor or a therapy team that's really good at figuring that kind of stuff out. You've mentioned a couple times already. So I believe you trained at NYU, and you've had experience at both Columbia and NYU, or? So
I did my training at NYU. Yeah. And then following that, I worked for several years at New York Presbyterian Columbia.
Right.
And then in Columbia, I did a mix of different things. I did what I'm doing now, which is a lot of aches and pains management. I saw a lot of the neuro patients dealing, kind of taking over when they were ready for that full rehab side of things, meaning you have a patient who comes in on day 0 of their stroke. The people who are treating them are going to be the ER doctors, eventually transition to the neuro team, ICU, and so on. And then eventually at some point, they transition from kind of acute neuro to needing rehab. And I was involved in the acute rehab unit that's there. And I also had some involvement in a facility that offered subacute rehab. I don't know if you want to go into that world, which we can if you'd like to. But basically, we took over as the coach or the quarterback of the rehab process. And it doesn't mean that they no longer saw their neurologist, but again, the neurologist kind of had the role of diagnosing, treating the underlying issue, and then also thinking about secondary stroke preventing this patient from having another stroke. And then we took over for, okay, how do we get patient now as close back to where they were a day before they had their stroke, and dealing with whatever issues might have come up as a result of that stroke, pain issues, functional issues, or so on. And, both of those environments, both of those hospital systems are very different in a lot of ways and very similar in a lot of ways. But I felt like I kind of had the best educational system coming out, and seeing the way those two systems work differently, and kind of learning from the nuances and seeing the different patient populations and learning from my predecessors, the senior doctors, even long after I was finished residency. I'm I was able to kind of lean in on some of the more seasoned doctors that were there and run things by them and learn from them. So I think it was a phenomenal experience in that sense.
So we've spoken about functional recovery a few times, and something that's interesting to me is that when I work in the emergency department, or sometimes even in an acute care setting, but more in the ER, when I see a patient that has a specific episode of something, right? And I'm always asked by patients, relatives, like, what's the trajectory? What's the projection here? Prognosticate. And I almost universally say, listen, now is not the time to prognosticate. We're doing everything we can to improve the situation and get him or her to the right clinician and physician and get him or her the best possible care, right? But for you, right, so you're on the back end of part of this process, and right, the incident has already occurred, whatever it is, right? The insult, if you will. And now you're integrated into the system. At this point, the patient or the relatives are kind of expecting like, hey, like, let's use stroke as an example. He had a stroke, right? His stroke scale score was high. So there was a significant loss of function. Are we going to get back to full function? And that is a conversation I really never have to have, because I'm able to put it off, because once again, it's not my job. And more than it's not my job, I'm happy to do things that are not my job. It's not the right time or the right place. But for you, I imagine that's when it starts to be the right time and place. How do you have that conversation? How do you know where the patient's going to end up? And sometimes if you don't know, how do you stay optimistic with the family with having a realistic perspective on it?
So the quick answer is we don't know. We can give estimated or intelligent guesses based on our experiences, based on other patients that we see. But the reality is no two patients are alike. And sometimes it's very difficult to predict how one patient's going to do versus the other. So I'll tell you what I've told patients, which you can use when you have this question, specifically with recovery from an acute brain insult like a stroke. Oftentimes we don't know in the beginning, because you have to see how things, certainly on an acute side, if you're doing an intervention or they're going to have an intervention like TPA or they're going to have if it's a clot, if they're going to have the clot removed, we don't know how fast they're going to get functional return. There's some dramatic stories where people are completely plegic going into the procedure and get near full return almost instantaneously, or a lot of return. But the answer that I give is we monitor over the first several days to weeks, and based on kind of based on how rapid the return is, that's usually a good predictor. Meaning, if somebody starts out with zero muscle strength on one side of their body, and they get an intervention, they have a thrombectomy, they have a TPA that's done, and then the following morning there's already return. I'm pretty confident that morning that I could say to the patient's family, this looks good. Things are starting to come back online. The longer it takes to see return, the harder it is to make that prediction, and sometimes the more severe that prediction. Now, having said that, sometimes it takes a week or two to start seeing some recovery, and sometimes it's more drawn out. If by the time I get involved, if I'm seeing a patient and it's now 4 weeks after the insult and they're still densely plegic, they have zero movement on that one side, I kind of explain to the patient that, look, it's not permanent, it's not definite, but the likelihood of this patient kind of getting full return on that side is looking less likely. We're going to do what we can. We're going to throw everything we have at this patient to try to get return. It's not impossible, but the longer that it goes with no return, the less likely something like that is. And we're going to start focusing on our efforts away from getting that person back to that 100% where they were before, towards how are we going to deal with this now change in what the person could do and can't do, and how can we work around it, and what tools can we implement, and how can we strengthen around it so that this person can be as independent as possible and feel good about themselves. So that's sort of the broader strategy that I'll employ. And I'll tell them I hope I'm wrong. Something that I learned in med school, shout out to the cardiologist, Dr. Chisner, I believe was his name. He said that I'm going to botch the quote, and I don't think he's listening to the podcast anyways, but, essentially, when it doesn't look good, you can let people know the facts, but don't ever take away hope. It's not our job, / it shouldn't be our job to take away someone's hope about
long-term recovery or, what their future might look like. You have to be realistic, but if someone, and once again, I guess if the hope is not realistic, right? If someone is an amputee or something like that, am I going to get my leg back? Then the answer to that question is no, because it's not realistic. But if there is the possibility of a return to function, right? And I think it's unequivocal. I don't know what the studies are, so I can't quote them offhand, right? Cognitive, mental strength in recovery is probably related to physical recovery, right? Like I imagine someone who has a negative, pessimistic attitude towards rehab and recovery, once again, I can't point at studies, I imagine they don't do as well.
I like that quote, first of all. I think that's very poignant. And I think a lot of us are, it's important to keep that in mind, where I think we can be realistic with patients, with family members, but we can say, hey, we're going to do whatever we can to get ahead of it. Now, obviously, if something's done, it's done. If a patient has died, they've died. There's nothing to do. So I think that I like to be optimistic with patients. I mean, there are times where I'll see a patient and I'll be like, hey, you need surgery. There's a bad nerve compression here. I'm sending you to a surgeon for an opinion. And I'll tell them, I said, I really hope I'm wrong. I really hope the surgeon looks at you and says, who's this crazy Dr. Rosenberg that sent you here? There's nothing wrong with your whatever spine or so on. So I think it's a good approach of, and it also shows empathy, frankly. I think, hey, I'm sorry to have to tell you this news and I'm gunning for you. I'm hoping that everything works out well. But I'm being realistic too, and and you're also kind of preparing them for this potential permanent change in their life. You asked about attitudes. I don't know if I necessarily agree with that fact that all patients who kind of go at it negatively will do poorly. I actually like, in a sense, when patients get angry. Like I find that that's a great motivating factor, especially if it's now, hey, they're coming to, they're in a rehab unit. They're upset that they've lost the ability to walk. They're upset that their arm and their leg are not working. I kind of want them to be angry because I want them to really push and fight to get back their function. A patient who's kind of complacent and turns to me and says, hey, I'm 89 years old. I don't care. Then that patient is probably not going to really fight for it. And they really have to fight because it's a struggle in that sense. Now, if a patient kind of is a more negative and sour person, I mean, they've been that way their whole life. So that's not going to change at that moment.
So I like that perspective. It's funny. I listen to podcasts. That's why we're here trying to create our own. But I do listen to someone named Chris Williamson. And a lot of what he has said is that there's a push and pull in life, right? What is your fire? And sometimes it's a pull. Right? Something's pulling you or something's pushing. So if something's pulling in this particular case, like I want full recovery, right? So you have like this positive, optimistic goal and you're going to get there because you're getting pulled there. And sometimes things push you away, right? Like, it's the fear or the anger of I'm not going to stay like this. And it's a different fuel, but over time the fuels burn differently, so to speak, right? There could be a flame out of, when you have a more positive route of looking at things, right? I think if it helps with your mind frame, sometimes the fuel lasts a little bit longer, so to speak. But I guess whatever works for the particular patient is really what matters.
Yeah, I think ultimately that's what's going to come down to it. If that person is a more positive person, they're going to approach it, positively. If that person is kind of angrier at life in general, even before then that's kind of how they're going to do things. Look, it's not to say that, part of what we deal with with these acute strokes, which is the example that we're running with, is dealing with things like depression or, and which is a completely normal thing to happen. A person can be really, really upset that they've been through this, and we have to deal with that. And we encourage things like psychotherapy. And if we have to use pharmacological interventions, we do it because it's important to kind of keep that in check also. And that can definitely hinder, if a patient's feeling too downtrodden and too depressed to participate and to work, sometimes then we do need to address those to help the patient to deal with that. So there definitely is, there's definitely wisdom to that a positive attitude will help. But like I said, I always find it amusing that it's those patients who kind of come at it with like almost annoyed that they're through this, that they're the ones who kind of work the hardest. Right. In a sense.
It's like a normal response to an abnormal situation is an abnormal response, right? Like someone should have an abnormal, so someone shouldn't be a laissez-faire or, label indifference is a clinical term, right? Like when someone doesn't care about something negative happening to them, right? Like someone should have a fire for whatever reason, angry, upset, sad, right? You said that depression, right? I don't want to say weird, but an abnormal or a strong response to a situation like this is not abnormal. Something that I think you might be insightful about is, and we'd spoken about it before, how does someone pick a doctor, right? Not necessarily a physiatry only question, and what we're trying to do here is get people to understand how to pick physicians. Who do you trust in a world where all the information is out there? If you could give 3 red flags, right? 3 things that if someone goes to a doctor, it's like, maybe you should find another doctor. What would be the 3 red flags that you would point to? And on the same token, I guess the opposite, like what are the 3 things that when you see in a doctor, because we're all on both sides of healthcare, sometimes we're sitting here and sometimes we're sitting on that paper, that kind of reassures you that you're with the right physician.
So for me, again, there are different types of physicians, right? So there are those super specialists, right? If someone's in a situation where they need a specific procedure done or a specific surgery and they're being referred to whoever the top in this field is, I think they're kind of, they're going there no matter what, no matter how nice that doctor is or how insightful. So I think what the question that you're bringing up is probably more on the primary care or maybe that initial specialist who they're seeing for whatever condition, right? I would say for me, red flag number 1 is not listening. A doctor that comes in and is not paying attention to that patient, is just reacting to an MRI or an X-ray finding, is kind of not listening to a little bit of the story, listening out for sort of key things. I think to me right away that's suspect. But yeah, I'm a big believer in communication. I'm trying to think of 2 other red flags that work universally. Certainly if, reputation is important. I think it's important if you're looking to establish care with a new doctor, ask around, especially in a close-knit community like this or some of the other firm communities. Usually people know everybody and, hey, I'm thinking of going to Dr. Smith. Anyone who's used him or her? Has it been a positive experience? Have you heard anything negative? I think just getting a general kind of ear to the ground, I think that's helpful. If certainly going on Google and typing someone's name in and kind of getting a sense of where they are. While it's not the be all end all, there is some accuracy in especially if you're reading reviews. I mean, you can see where people are, and you can see if they've upset enough people enough, and there's going to be enough negative reviews. It's probably telling about who you're going to see. But to me, like I said, you want someone who's listening and reacting to the data that they're being presented or the inputs that they're being presented. You want overall positive reputation. Again, that I don't know if I'd put that in the red flag territory, but I think that's something that can be helpful in terms of picking somebody. And I think, outside of the other red flags, there's a history of abuse, there's a history of malpractice or so on, sort of the terrible stuff. I think the patient, especially on the primary care setting, they have to feel like they can relay what's really going on inside. They have to have a level of comfort and connection with that doctor. And if they feel time and time again that they're being talked down to, that the doctor's being condescending, I know it's the same thing, and they're not able to sort of express what it is they're going to, then that person needs to find somebody else. Even if that doctor is tops in the field and wears a really nice bow tie every day. That's to me, anyways, that would be sort of a
seems like you're singling someone out with a bow tie, but yeah.
Maybe.
It's I like how you put that, because I think initially there was a struggle, like, how do you figure out who the red flags are, which is the doctor with the red flags, and I think that's poignant because the answer is it's so difficult, right? It's obviously the threshold to become a doctor is exceedingly high, right? It's not the easiest career pursuit. But that being said, there's a variety of a cast and crew, so to speak, who can become physicians and clinicians of all kinds, right? And the biggest disconnect between us and a patient is our information gap, right? Like we have information that they don't necessarily have access to. They haven't put the time or the energy that we've had to put into it. So there's this large gap. And how do you ensure as a patient that you're seeing someone and that is the correct person? So, right. Like I think it's the 3 C's. It's communication, it's consideration, and connectivity, right? So like you said, are they communicating well, right? If then I say something to them, are they considerate, right? So sometimes communication is, they can say exactly what the treatment plan is. Wow, I understood that perfectly. But I'm actually concerned about this part. Are they like reflexive about it? They're like, oh, you know what? Maybe for you, we have to do something differently. Now that you mentioned that, let's do, right? And then I like you said, this last part is the connectivity, right? Like this, if it didn't, it's the best doctor, 1,000 referrals. You left the room and you just felt like, I don't know, that didn't feel right necessarily. I think that's also maybe not a red flag on the physician or the clinician themselves, but maybe just a red flag that they don't speak to you and there's another doctor that is just going to have a different level of connection that you're going to really buy in to whatever the treatment plan is. Because a firm believer, if there's no buy-in and connectivity with the physician, then it doesn't matter how great the treatment plan is. It generally is not going to come to fruition. I think this is a great opportunity for me, so I'm going to take it, right? You're the rehab specialist. I'm the emergency/acute care, urgent care physician. What are the things that you wish we would do from an emergency room perspective that maybe we don't think of or that we don't do? And maybe it's a lack of time. I give credit where credit's due. It's a tough job. But maybe there are easy things that we could integrate into either our exam or how we communicate, or do something up front for a patient that over the long term would be more beneficial, even if it's purely education. We see back pain and all these things all the time.
I think there's a lot of layers here, and I keep saying that, but there are
everything's layered.
Everything's super
like
layered.
An onion,
like a big onion. I think things that I number one, I would say for what patients need to understand when they're going to an emergency room is that it's a busy place. Even on the best of days, it's a busy place, and the mindset of the emergency room staff, techs, nurses, doctors, PAs, NPs, whoever's in that room. It's going to be constant triage. Essentially, you're going to be most focused on the patients who have the highest potential for something to go wrong, the patients that are coming in that are crashing, the patients that are really significantly sick. They're going to be the ones who are going to occupy the most brain space of whoever it is that's treating them. So if someone is going to an emergency room with a complaint of back pain, for instance, and they're not necessarily signaling some of those red flag symptoms or those really concerning symptoms to that staff, they are not going to be as, I don't want to say well treated because it's not the case, but they're not going to be as prioritized as those patients who are with significant risk to life and limb. So I think that's important that patients have to understand that when they're going to an emergency room, it's very different than when they're making an appointment and seeing their doctor or their provider, because it's just a whole different environment, right? Altogether, right? So I think that level of understanding is important for a patient to understand that even if I'm sending them to the emergency room, they're not going to be the number one priority in that room, even if I call. Like I've just had this, can you call the emergency room and tell them that I need an MRI? I'm like, that doesn't work that way, right? That's A. I think from the emergency room, what do I want the providers to know? I think it's important, and I'm glad you brought up that example, which is make sure that patient can walk, make sure that they're able to, that they're, you don't have to do a detailed neuro exam, but make sure they're moving, they're both of their arms equally and their legs equally, and that they can walk without toppling over. I think that's, we want to delineate the difference between a really, really serious spine problem that needs urgent attention from the classic back pain that can be addressed in an outpatient setting. And sometimes that distinction is not obvious. So I think that's important. I think a baseline set of x-rays can be very helpful. I know it's tough to get CTs and MRIs on patients that you don't need them for, and I don't expect you to CT and MRI everything. But I think if a patient's coming in with a neck pain or a back pain or a shoulder, getting a baseline set of images can be helpful, and certainly at least gives you reassurance that you're not dealing with an underlying fracture or something that's maybe not, in the box, and that would change the way that you treat that person, and also can be helpful for the first person who's going to see that patient, with what they're going to do. And then certainly there's a push and a realistic push to not prescribe opioids. So I think that's important to maintain that as much as possible. But at the same point, you want to make sure that they have some coverage. So medications that can help with the pain, be it anti-inflammatories, muscle relaxers, medicines to help with their nerve pain, all those can be very helpful, at least towards getting that patient feeling better. So I think, at least from the patients that I normally see, I think those would be the little bits of information I'd want to impart to at least emergency room staff.
Two things on that. The first thing is that a few weeks ago there was a patient in an undisclosed location, and the patient had recently left another facility and was coming in with really the complaint that they had lower back pain and they had a tough time moving their legs. And I know because, and this is a socioeconomic thing, right? Because of some preconditions or preconceived notions people had about the patient and their status, I feel like there was a strong likelihood that the patient was discounted previously and could be discounted again. And I was working with someone on the case, and I was like, we have to do imaging. I feel like there's a red flag here. And then sure enough, there was an operable lesion in the spine that did require management. And it's something that I always try and impart on. Sometimes I'm working with medical assistants, I'm working with medical students, I'm working with PAs. It's a collective, and I just say, like, you have to take the patient's word for granted, right? Until there's enough information to disprove that what they're feeling is, you can't find any organic, physiologic, diagnostic reason for it. You absolutely have to take what they're saying as the gold standard and work off of that assumption, because you cannot discount people purely based off of any preconceived notion, which in medicine, that's our duty, right? Our duty is to ensure that we are taking care of everyone to the highest standard at all times. So I can certainly appreciate that.
I would just add to that. Make sure it makes sense. Like if things don't add up, trust your gut, trust your intuition. There's been, unfortunately, enough times, doesn't happen frequently, thankfully, but it has happened enough where, gotten referrals for back pain, and everyone's saying, oh, just, put them on. I'm sending, from other providers, I'm sending the patient to you. Maybe you can do a shot. Maybe you can give them some cortisone, and we can go into that differently, but, maybe just get them feeling better. And I've gone in there and sort of taking that step back and saying, hey, this is not adding up, and pushed imaging and found things like lesions or so on. So I think it's important, and is when you're walking out of that room or when you're done with that patient encounter, to sort of like do that mental checklist of, does this make sense? What I think this is, does it check off all the boxes? Is there anything here unanswered? Is there anything here that doesn't fit the mold? And if it doesn't, what do I need to do to make sure that I'm not missing something? It doesn't mean that you got to do your full workup in the emergency room setting, but at least forward plan and say, hey, and even explain to the patient, I think this is what it is. I do want you to see a specialist or your primary care provider, because I'm not sure about X, Y, and Z. I don't think it's a reason that you need to stay in the hospital, but I think it's something you need to follow up. And I think that will at least, and number one, from a medical legal standpoint, you can document that in your notes. This is not answered, but I'm having them follow up with their primary provider. And number two, it's important to at least relay that to the patient so that they know and have the best chance at an appropriate workup. Yeah,
I appreciate that. That's good insight. Moving into, I guess, more bread and butter conversation here, right? I think a lot of what you do on a daily basis in the clinic is MSK related. I just wanted to, from an educational perspective, kind of let people know, if they experience X, what is the possible trajectory? What are the different modalities of treatment? Because I think that's really valuable. Before we get there, the one thing I quickly want to ask, because I think it's super relevant. I think in every field of medicine, people are trying to look for the attractive alternative, right? And that's human nature, and it's completely understandable. I think in general, the snake oil salesman, the quicker the resolution for the harder the problem, that's that's generally when you should be concerned about it. But it's super appealing, right? Because I have this problem now, I want it resolved now, and someone's going to sell that to you. Are there any therapies, alternative therapies, modalities, two-part question really, the ones that you've seen that are harmful, right? People are trying them and you're just like, please don't do it, right? Because you think it's overall not just a waste of money perhaps, but could be detrimental to their health. Alternatively, are there any of these what people might consider alternative that you've used on patients and had some actual benefit from? So I know there's a lot of questions. I don't want to give you anything particularly to speak about, but I know there's a lot of probably nebulous treatment plans out there and treatment modalities that maybe you could address.
There's a lot that's out there. There's certainly a fair amount of quackery that's out there, and I can't really speak to specific ones, but certainly if someone is pushing some type of a supplement, be aware that supplements can be medically active, they're certainly pharmacologically active, and can certainly interact with other medicines that you're taking. They can replicate other medicines that you're taking, and can have side effects.
Right, and just to that point, I think what happens is from a rap perspective, they always get the rap of, because they're alternative, inherently they're not pharmacologically active, so they can't be dangerous.
Right. There's a bit of that. I think there's two things that happen. Number one, there's a pushing on the natural side of things. Oh, this is a natural blood pressure medicine. This is a natural pain reliever, which it may or may not be, and therefore is not the same as whatever medicine that I would prescribe or would interact with whatever they're taking. I think there's a lot of alternative treatments. I mean, that's without specifying specific ones that are out there. I think you just have to kind of go in. I don't have an objection to most of them. I think they're harmless at worst for a lot of them. But I think I think it's a reasonable conversation to have with your medical provider if you want to discuss it further. Say, I'm thinking about doing whatever treatment, for argument's sake, talk it over, make sure that it's not contraindicated with whatever medicines that the person's taking. That's number one. I do want to talk about one thing individually, and it's been a bit of a pet peeve of mine for a while. So this is a great platform. A lot of folks lean in on treatments that focus on emotional health, meaning there's a movement out there, and it's been around for a long time, to say that, my physical well-being or my physical detriment is coming from an emotional issue, meaning it's basically a mind-body issue. So specifically, there's a treatment, there's the Sarno method, which was originated by Dr. John Sarno, who's a physiatrist who I actually had the pleasure of meeting and chatting with, because he was over at NYU and I were there. We overlapped briefly. Brilliant man, brilliant doctor, helped a lot of people. And he focused on essentially kind of telling people it's okay to have back pain. It's okay to have a shoulder issue, a knee pain. Let's kind of deal with the way that you deal with pain as a way of kind of accepting it and kind of using that to overcome it. Right. So I'm certainly not an expert in the Sarno method. I understand it. I've read the books. I've seen the lectures, and it's helped a tremendous amount of people. And I'm not here to knock it. What I do want to bring attention to, and this is something that he's mentioned in his books, is that it's important to have the medical workup first. Have the medical workup first to rule out other issues. I've unfortunately been witness to, and I've heard of stories where folks with a presentation of back pain will kind of jump to a method, either Sarno method or something similar, kind of buy in, do the work, see therapists, read the books and so on, and kind of have missed cardinal things, and will have something a lot worse going on underneath that was causing the pain. So understand that number one, if you're dealing with a new issue, a new pain issue, or something's not right, get it checked out appropriately first. Make sure from a medical standpoint that it's not, that everything is in order. And then, beyond that, I think it's a wonderful treatment. It's helped a lot of people, and I refer people to do it when I think it's appropriate for them. But my point is it's not the first line thing that you do the minute you wake up and your back is hurting you. So I think that's important. And then getting back to the original question, which was, are there harmful treatments out there? I think there are always going to be people who will prey on the most desperate people. And unfortunately, I've seen this, getting back to the example with stroke recovery and, MS or Parkinson's. There are doctors, there are therapists, there are people out there who are hawking various treatments. And people will travel great distances to go get these treatments, and people will pay an enormous amount of money to get these treatments, and rely tremendously on them. Some of them can be dangerous, frankly, to administer. Some of them can be unnecessary, and some of them can be a complete ripoff when technically you have something that's closer to here. I don't know if you want me to get into specifics, but I will just kind of allude to one treatment that I heard of where someone was going to another state, and they were having this is a patient who had a stroke. They were having an infusion into their spinal canal of a chemotherapy drug to try to reduce the swelling around their brain that would lead to the hemiplegia. And this was about 15 years after the stroke. So again, there's no literature for it. It's an unnecessary lumbar puncture. It's tremendous amount of travel and expense. And it just, I think if someone's offering that to you, do your research, talk it out, kind of, approach it from a logical perspective, trust your gut, and understand, like I said, there are people who are out there that are offering false hope with the understanding that people will do anything, especially if they have the resources, to get back to that state.
I love how you said that. I think life is a zero-sum game, right? If you're doing one thing, you're not doing something else. There's always an opportunity cost. And once again, there's a knowledge gap, right? If someone doesn't know better and someone is offering them what seems like a miracle cure, sometimes that's what people are going to rely on, right? Like if there's an opportunity, even if it's 1 in 1,000, 1 in 10,000, people are going to give it a shot. And when you don't have the medical background to understand even mechanistically why something should or should not work, it becomes very, very attractive. So it's definitely important for people to know about. I also like what you said about, psychologically dealing with pain and managing pain through being psychologically proactive about it. At the same time, don't do that at the expense of not actually having the appropriate medical workup. And that segues actually pretty nicely into the aches and pains, which is your area of expertise, so to speak, and every other doctor shies away from it. But I just want to do some clinical scenarios so, we can educate as much as possible. If someone comes in with X, what they should do. So, let's say someone wakes up, in their lower back pain, they didn't have any attributable cause to it, and it's day one, lower back pain, it's, let's say, moderately uncomfortable. What are the things they can do at home before they come in? At what point should they come in? And at what point should they say, I need to go see another doctor or a subspecialist or a specialist?
So I think we need a disclaimer here before we start, which is...
We have it at the beginning of the episode.
Okay. This is not direct medical advice for any individual patient, and certainly reach out to your doctor. So I think the
we're going to do that for actually, we had a different voice, but I like your voice better. So we're going to... Yeah. It's more soothing. Go ahead.
There we go. I should have chose my terminology better. I think, look, if something, this goes back to, trusting your intuition, it's certainly better to go to the doctor or go get things checked out if you're not sure what they are and being told, hey, it's fine and you'll be okay in 2 days. I think that's better than ignoring something and potentially having something devastating occur. But having said that, so the way I think about pain, and this is the way I phrase it to my patients, is this pain stopping you from doing something? Meaning, you wake up with a backache. Is that going to stop you from going to work? Is that going to stop you from going to shul? Or it's just kind of there and it's in the background and you're able to kind of get through it. So if it's not really in the way and it's the first time you've had this and you're able to get up and there's nothing that sort of seems abnormal and you've able to use the bathroom without losing control, and there's nothing that seems sort of wacky or odd, I think that's typically reassuring, at least to me. That's if that same person's waking up and their pain is really significant and they're writhing and they can't find a comfortable position, and they certainly if they try to get out of bed and they're losing stability, that's call Hot Solid, call 911, get checked out. So I think those are the sort of the two extremes. The question is, what do you do sort of in the middle? And the answer is, it's hard to say. It's a case-by-case basis. But if strength-wise things are intact, bowel and bladder are intact, that's usually pretty reassuring. You don't have to go run to an emergency room, but probably makes sense if it's not better with an anti-inflammatory medicine like a Tylenol or an ibuprofen to kind of lean towards getting that checked out sooner. Having said that, we all will do things like pull our backs or get a stiff neck. And I think most of us, by the time we hit adulthood, know what our normal kind of back ache or neck ache is. And, if it's sort of day 0, day 1, and I think that's reassuring. If it's several days and it seems to be getting worse or not getting better, then I would say at that point, you probably want to make an appointment and get checked out.
I like how you handled that. Not only because of the medical disclaimer, which I enjoyed, but I think also because, it's a nebulous complaint, right? I mean, by virtue of it being a symptom and not a final diagnosis, it could be anything from as small as a muscle strain to as severe as a spinal lesion, God forbid. But, it can happen and everything in between those. And right, if it's not terribly severe, then it's something that you maybe try and manage. You figure out when you have to go to the office, get checked out. And then obviously if it's so severe and there's any other symptom, we talk about red flags a lot, urinary bowel incontinence, right? If you have any numbness in your legs or weakness, those would be obviously indications for someone to get checked out immediately. Something else that you probably deal with is cervical radiculopathy. What is it? What are the treatment modalities? When should someone get checked out for it?
So again, by cervical radiculopathy, for those who are not well-versed, what that means is it's a nerve in the neck. So the nerves that are in the neck, they go out and they feed the muscles and the muscles in the arms, and they also feed the skin in the arms. Meaning, so all information that's going back and forth from the arms, sensation, muscle strength, and all that, that's being routed to the brain through the cervical spine or through the neck. So by cervical radiculopathy, what that means is that something in the neck is putting pressure on that nerve, or one nerve or several nerves that are going on their way towards the arm. What that normally feels like, what the normal presentation is, it's usually neck pain, difficulty with moving in certain positions. So sometimes it's easier to look down and look up. Sometimes it's easier to look up than look down. And that usually will come along with numbness, tingling, burning, pain down the arm in a specific pattern. So we wouldn't expect the entirety of the arm and fingers to be in pain, but you almost look like a zebra stripe along the arm. So when should you be concerned? Certainly if there's a loss of balance, if you feel like it's tough to walk, if someone feels like it's tough to walk, tough to hold themselves, they feel dizzy, those are reasons to get this looked at sooner rather than later. Again, muscle weakness is usually a red flag symptom. If someone comes in and they're having trouble holding packages, lifting up their arms, that's usually an MRI for me sooner rather than later. If a patient comes in with those symptoms, usually I'm checking their strength, I'm checking their reflexes. If I see a change in a reflex and a deep tendon reflex, if I see a change in strength, I'll push to have an MRI sooner rather than later, just to see, because I'm worried about long-standing neurological damage. Those patients we usually treat pretty aggressively with pain medication. So oftentimes that'll be some oral steroids for a couple of days. Sometimes it's anti-inflammatory medicines like the ibuprofen family of medicines. I'll use muscle relaxers on occasion, like Flexeril or Xanaflex, or any host of those types of medicines. I'll sometimes throw in a medicine for nerve pain, like gabapentin. Once I assess with imaging that things are stable, that there's not a significant danger to permanent neurological damage, I'll usually refer them out to do some physical therapy. But I try to get their pain better controlled before they go do physical therapy. Meaning, if I have a patient who's in severe pain, they're probably not going to do so well with therapy if they can't tolerate it. So I'll try to, my initial approach is get them better with medication, get them from a 10 to a 7, get them from, meaning on the pain scale 0 to 10, 10 being worst pain ever, 0 being no pain. If patients are at a 9, 10, my first goal is to try to get them down to a 7, 6 so that they can be a little bit more functional. So they're sleeping, they're doing the things they need to do to get through their day. They're probably still in a lot of pain, but they're managing. And then in that case, I'll usually have them see therapy to start working on that. Occasionally, we offer what's called an epidural steroid injection, which is a way of getting steroid medicine or anti-inflammatory medicine at the point where the nerve is pinched to try to reduce some of that irritation and make that pain better. So that's kind of the general approach towards cervical radiculopathy.
Shoulder pain and knee pain, obviously there's a tremendous amount of causes there, but when someone's made their way to you and they have this persistent discomfort without any significant diagnosis, right? They don't need orthopedic surgery or anything like that, but they're just chronic pain, maybe from arthritis, which I think is probably a classic cause. What are things that they can do at home, relatively speaking, and what are things that you can do for them?
So there's, like you said, there's knee pain and there's knee pain, there's shoulder pain and there's shoulder pain, meaning, a 20-year-old with knee pain is going to be approached differently than a 70-year-old with knee pain. Let's go with a more common scenario here, which is if someone's a little bit older, they're north of 50 or 60, they've kind of had this sort of chronic aching in their knees. Usually, typically, so I'm alluding to like a knee arthritis scenario. So there's pain when they're laying flat. There's some pain with going up and down stairs, pain with walking longer distances, potentially some swelling. Things people can do at home, certainly over-the-counter anti-inflammatories, as long as it's not contraindicated with their other medications, obviously. Disclaimer time. Trying heat and ice can be very helpful. I don't have a preference, whichever feels better, honestly. And actually being mobile is helpful, although it can be painful at first. But strengthening their quads, doing things like straight leg lifts, help to take some of the pressure off of that knee and help to reduce the pain. Certainly, lifestyle modification. If someone's obese, losing some weight will definitely be helpful in the long term. Maybe not in the short term, but certainly in the long term can be helpful. Having an X-ray to see what degree the arthritis is can be helpful. Those are sort of the baseline starting point things that can be done. Beyond that, when they come in to see me, in addition to that, all the above that I'll counsel them on, we'll offer things like physical therapy to have someone actually direct them on exercises and things they can do at home. I'll offer some injections depending on how the arthritis looks. So sometimes we'll put some a corticosteroid like triamcinolone or any of the other steroids into the knee by through an injection that can help to calm down any acute irritation or inflammation. I usually look at the knee with an ultrasound just to see if there's an effusion or if there's a lot of fluid coming out of the joint. If there is, I usually will offer to drain it take out the fluid and put in some steroid. That can usually help with some of the acute pain. And then we talk about additional options. Once we do a steroid injection and the pain is improved, then we think about, okay, what can we do now to prevent worsening of pain? What can we do to prevent the worsening of the arthritis? So again, that goes into some of its lifestyle, eating better, losing weight, exercising. Therapy is helpful. We'll do injections of viscosupplementation, hyaluronic acid injections. So these are medicines like, this would be things like Euflexa or some of these other brands that are out there, which act as they call them the gel shots essentially, but they're medications that are similarly in a molecular state to the cartilage that's lost. And it's not as active as some of the other medicines that we use. So, if I had the choice between doing a gel injection or a steroid injection, I'd prefer to do the gel because it's going to have less systemic effects. It's not going to raise somebody's blood sugar. It's not going to potentially increase the rate of the arthritic changes. There's questions about do steroids fast track osteoporosis or osteopenia. So some of those things we can avoid. In my head, it's steroid injection in the beginning to put out the fire, so to speak. If a patient's coming in really acutely in pain, we'll offer steroid to calm things down. We'll have them come back about a month later to think about doing a visco injection. We'll have them do some therapy. We'll do some lifestyle stuff to really just try to mitigate some of the pain. Now, there comes a point where all the above doesn't work, and we'll start talking about knee replacement if the degree of disease is that far in advance. And then there's other options that are out there that things like nerve ablations, genicular nerve ablations. They're kind of higher level pain management type stuff where we can kind of take the nerves that send the pain signals, take them offline so the patient's not feeling as much pain. There's some some regenerative stuff that's out there, things like platelet-rich plasma that some folks are doing. People are even getting into the realm of stem cells, so there's a lot that's kind of out there on the periphery too that people are doing to try to help with some of the arthritis pain.
What's the evidence as far as, and I'm not asking you to be an evidence expert, but I know that sometimes you get into these treatment modalities and anecdotally people feel good about them and the evidence doesn't necessarily back it. And I'm not well versed with evidence. I'll use that as my personal disclaimer, but from what you've seen and what you've heard, what's your knowledge?
So what do you mean by that? Like which specific?
Yeah, meaning what are the therapies that are more cutting edge that maybe people are doing without as much of an evidence background, or alternatively ones that it's taken some time, but at this point we kind of have more information on them, and it seems like they're more common practice and they're more common practice and procedure for your average physiatrist. Yeah,
I would say, well, I'll start with sort of like the standard approach, the accepted approach, which, most physiatrists, most orthopedic doctors are doing are going to be things like, therapy, lifestyle modification, weight loss, which I guess goes into under the category of lifestyle modification. There'll be injections consisting of steroids and, the visco. Those are sort of established. The evidence is there. Medicare, all the insurance companies basically have accepted it and cover it, provided, they meet their criteria. Certainly like over-the-counter at-home analgesics like Tylenol, ibuprofen, those can be helpful too. So that's kind of the standard stuff. And similar to what we spoke about before, there are those that are kind of offering stuff out there, especially people who are, desperate enough might be tempted. I think what we're seeing kind of on the periphery of that, so the things that are not yet established as standard practice, but I'll go kind of in order of what I think has kind of the best potential, and the evidence is slowly coming in. It's not quite there, so it's not quite to the point that it's established medical practice. I think the first line would be a treatment called platelet-rich plasma, which is a blood sample is taken, the plasma portion of the blood sample is separated out, so it's centrifuged, the plasma portion is taken out, and then that can be re-injected into the knee. There's a lot in that world, and certainly there's things like how many leukocytes are you getting in your sample and all that. So there's a lot of back and forth on there, but we're definitely seeing, certainly anecdotally, it's very helpful for pain from arthritis. It's certainly very helpful for some soft tissue issues like tears or so on. And I've certainly seen that in my practice where patients report that it can be very helpful. I think a step kind of deeper into the weeds would be things like stem cells, where we're actually extracting stem cells from like adipose tissue, or even from doing things like sorry, I'm blanking on the word. But let's say, for example, we're basically getting stem cells from bone marrow, for example, like pulling out BMAC or so on, getting a bone marrow aspirate and then taking that and injecting that into the knee. I think there's a lot of people who are doing it. And again, we're talking about things that are not normal, not typical, not covered. I don't think the evidence is established yet for that kind of stuff. We also kind of don't know what the stem cells are fully capable of. So, I don't know that we've seen it all yet. But there's a lot of people doing them out there, and they seem to be getting decent results. I think those are kind of the ones that you'll read about or you'll see a lot of. And then there's a lot of the fringe stuff. Right? There's different types of pain medications, use of various peptides. There's a whole world, and today, anybody has a wild idea and can put up a website, can put that out there, and it's tough to know as a consumer, how much actual scientific weight there is, or how much can be done. But I think that's going to be what you'll see as sort of the most typical stuff that you'll read about.
Well, I think I appreciate you answering the question to the best of your ability, because I think for the average consumer, patient, client, right, it's all one pot of possibilities, right? And without having someone kind of layer it as to traditional, advanced, maybe unfounded, right? Like without someone peppering out the details for each one, it just becomes a soup of possibilities and opportunities, and it allows, bad actors to take advantage of patients. So it's certainly helpful to get that information. A little bit more complex. I don't know how comfortable you are answering, but it's certainly interesting question. I think it falls into your wheelhouse. Patients that are diagnosed with things like fibromyalgia, complex regional pain syndrome. These are tough for the average person to deal with on a daily basis. Sometimes it takes a while for them to get these diagnoses. Sometimes they get other diagnoses. It's unclear. I think for the average doctor who's not you, we don't necessarily know what to do with it, right? Like if I have someone coming to the ER with those medical conditions, complaints, and acute discomfort, well, I only have the tools in my toolbox, and I'm not exceptionally well versed in those diagnoses and how they were made. So I can only do the best I can for that patient in front of me, but I don't know if you're comfortable commenting on them or discussing them.
Sure. I mean, I'll do the best I can. And they're both excellent topics. So I would separate out fibromyalgia from complex regional pain syndrome. The reason being is that complex regional pain syndrome tends to be more localized and tends to oftentimes, not always, but oftentimes will be in the setting of having had a prior injury to that body region or even an orthopedic surgery or so on. So it does seem to kind of line up with some type of an inciting event. Now, both of those conditions are super difficult to treat, and there's not a lot of great treatments out there. I'll start with complex regional pain syndrome because I think that one to me is better understood because it's kind of finite. So typically speaking, it's going to be it used to be called reflex sympathetic dystrophy. They ended that now because you can't prove that it's a sympathetic issue. So there's CRPS1 and CRPS2. CRPS2 is more chronic than the number one, and there's nuances in the difference of definition. But typically, like just to kind of layer to break it down in a easier to understand fashion, you would have somebody have an initial injury to a body part, be it a leg, be it an arm typically. They may require some type of surgery to deal with that, like an orthopedic procedure. And then post-injury or in the injury recovery, the typical symptoms are going to be things like hypersensitivity, hyperalgesia with movement of the arm, just like significant pain and difficulty with mobilizing that out of proportion to what you would have expected with that injury. Traditionally, the way to treat it was things like desensitization with therapists, so like light touch, getting them more comfortable with being touched. You can diagnose CRPS. It doesn't always mean with imaging testing. So there's usually like a triple phase bone scan will show increased uptake with CRPS. Now, if somebody has a negative on that test, does that mean that they don't have CRPS? Not necessarily. You'd still treat it. The gold standard for treating it was with oral pain medication. So oftentimes opioids or anti-inflammatories. Some were doing like bisphosphonates, even IV bisphosphonates. There's some out there that are doing oral steroids for extended periods of time. So I think that's, to me, easier to explain because of the kind of the finite nature of the disease. With fibromyalgia, it's a tougher one to diagnose, and it's a tougher one to specify. There's no blood test for it. There's no imaging study. Essentially, it's the patient kind of having symptoms where they have specific points of pain at distinct parts of their body, most of it like behind the neck, behind the back. Oftentimes comes along with an underlying condition of depression or anxiety. And the problem is there's not really a great treatment for it. So we'll do things like physical therapy just to help promote mobility. We'll do things like various antidepressants, things like Cymbalta or even Elavil, which can be helpful. But oftentimes these patients come in already on an SSRI. So I can't give somebody an SNRI when they're already on an SSRI. So they're tougher to treat. Those patients actually do better with some of the psychological treatments for pain, things like the Sarno method or the various psychotherapies to help them kind of address their pain. But that's the sort of the tougher one to treat of the two.
If you could go back when you started this journey and whisper something to your like, hey, this is your piece of advice, something that would get you through the whole process, what would that be?
I think it's, be patient. I would tell myself what I've told myself, which is, put that one foot in front of the other. There's be curious, ask questions. Don't rush the process. It's going to take time. The cynical answer would be, don't do it. There's easier ways of making money, which a part of me would say to that young medical student. But I know in my case, and probably in your case, that I could have had 500 people telling me, don't do it. This is not there's a lot easier ways of making money, and I wouldn't have listened. So ultimately, I think it's just this is a process. It's lengthy. It's challenging. There's going to be ups. There's going to be downs, and you just kind of have to focus on the small victories and map out what you need to get done for that day and get it done. And that's your victory for the day. Obviously you have to have big picture if you're going for, again, assuming there's people who are in medical school or trying to get into medical school, and if you're aiming for a specific residency or a specific school, you have to do your research and understand what's necessary to get into those programs are and work towards that. But I would break it down day by day and just kind of get through. And time has a way of passing by. Hey, we're here, you and I both, and we probably never would have imagined when we were in our mid-20s that we'd be sitting at this point and what it'd be like.
I'm still in my mid-20s. I don't know what you're talking about.
Okay. Lucky you.
I love what you said, though, as far as be curious, because I think in medicine we jump to judgment before curiosity, right? Oftentimes with our mentors, with people that are maybe coming after us, right? People that are learning from us, from our fellow clinicians that are taking care of patients, and we have joint patients, and even from our patient, right? Like sometimes you pass judgment before you ask the question, well, I wonder why, right? Just if you're curious, that's when you're probably going to make the best possible connection. That's when you're going to catch things, versus passing judgment. That's when you're going to be quick. That's when you're going to be unapologetic in how you're operating, right? Be curious at all times. Dr. Shmuley, that's what we're going by now. I appreciate you coming in today, and I appreciate you sharing your view on medicine and specifically all your clinical pearls in physiatry. And I look forward to doing part 2, because it seems like we scratched the surface. There's plenty of topics that I want to talk about we didn't have a chance to talk about, but thank you for coming in.
It's been fun. It's been my absolute pleasure.